Good morning, everyone, and welcome to the special session dedicated to the issue of human rights and TB infection. If those sitting in the back can come forward, we're like just among each other today, so I think that makes us feel closer. My name is Zied Mahirsi. I'm from Tunisia. I'm with Physicians for Human Rights, and I'm really happy today to have a fantastic group of speakers that's going to walk us through the issues that are related to human rights and TB. TB infection particularly, but TB in general. This is the only session dedicated to human rights at the conference. And we're hoping that this will become not only a tradition, but will take larger and more time from the focus of the different delegates. I think that I'm not going to speak too much. I just want to say that I'm a physician and that I had to treat TB in a former life. From that TB, I think I have latent TB. I don't know. I had a reactive test, but I didn't push it further. I don't know what my rights are, and my country was just dropped by the Global Fund and deemed non-eligible for funding anymore. So I'm hoping that my speakers are going to show me and tell me more about my rights. So without further ado, I'm going to give the floor to Daniel Collins, Colin Daniels. Sorry. So Colin has 18 years of experience in HIV, TB, and health and conflict in fragile settings. She's a human rights and gender expert. She has been responsible for developing and implementing successful advocacy campaign on TB, HIV. Many of you already know her, and she's currently working to ensure human rights barriers to TB implementation and services are removed and that they are gender sensitive. She actually also working on making basically the engagement of communities in the TB response more effective and more equitable. So to you, Colleen. If you want to go there or sit here, I mean, there's no difference. It's up to you.
Can I put my slides up here? Okay. Morning, everybody. Thank you all for coming. It's nice to see so many familiar faces and so many new faces. I'm just going to talk this morning a little bit about the framework for human rights and some of the work that we at the Stop TB Partnership are actually doing to be able to push this agenda forward. So who is the Stop TB Partnership? We are an organization of over 1,300 partners in more than 100 countries around the world, and we all have the same mission. We want to be able to serve every person who is vulnerable to TB and to ensure that they receive high-quality treatment to anyone who needs it, any form of TB, anytime. So what are human rights when we're talking about it in terms of our strategy? We're looking at human rights as equality-driven, gender-based approach to TB, which is actually grounded in international, regional, and domestic laws. These laws recognize that all human beings have equal human rights regardless of their nationality, ethnic origin, sex, race, religion, or any other status, and are built around core human rights principles. Human rights, of course, have not received as much attention in refining the global TB response. And however, they're no less important. And in actual fact, this year with the WHO Global TB report showing that we have more TB than we ever thought, more deaths than we ever thought, and we're missing more people than we ever thought, we have no choice but to address this in a holistic way. It can no longer be about TB control. When we're talking about TB elimination and ending TB, it has to be a patient-centered, human rights, community-driven approach. So what are some of the key principles guiding a rights-based approach to TB? I'm not going to go through all of these, but just to put it into a framework, it's universality. That means human rights are for everyone. It's indivisibility and interdependence. They're interdependent. Human rights are interrelated. And the indivisibility principle recognizes that if a right such as the right to health is violated, it necessarily affects people's ability to exercise other rights, such as the right to life and the right to vote. It's about equality and non-discrimination, accountability, where we must hold government and other actors accountable for failing to uphold the services that we need, their obligations, and participation, where people have the right to participate directly or through capable representatives in decision-making. And that's at every level, from development of an idea or a policy through to implementation and monitoring and evaluation. And this then the right to health sits within these guiding principles. And it's also important for us to always remember what these rights are. It's availability, where we have a sufficient quantity of functioning healthcare facilities, goods, and services for diagnosis and treatment of TB, as well as adequately developed and updated TB programs. So TB programs that are still working on guidelines or policies from 10 and 15 years ago, they need to be updated, and we need to hold them accountable for that. Accessibility. I won't talk a lot about this because Jonathan is actually going to go into great detail. Acceptability. So health facilities, goods, and services for TB must be respectful of medical ethics and culturally appropriate, as well as sensitive to gender and life cycle requirements. And of course, quality. So health facilities, goods, and services must be scientifically and medically appropriate and of good quality. So a good example would be scaling up gene experts so that they're used nationally instead of in pilot projects or small area projects. Because we know that smear microscopy is an old diagnostic tool that is not very accurate in, for example, children or people living with HIV. So that's a good example of how we need to improve the quality of our services, and it is a right that we all have. So what are we doing in the Stop TB Partnership? Together with the Global Fund, WHO, and others, we're actually looking at our key and vulnerable populations in TB. We've never done this before systematically. So we've actually defined what these key and vulnerable populations are. So they're people who have increased exposure to TB due to where they live or work. So for example, healthcare workers, prisoners, prison workers, minors, people who have limited access to quality TB services. So they could be mobile populations such as migrants, internally displaced peoples, refugees, and people at increased risk of TB because of biological or behavioral factors. So people with a compromised immune system, like HIV. So from that, after that, having that definition, we then looked at some of the key populations. These are not all of them. There is no way that we could, with our limited resources, be able to define everyone, particularly because it can be very country-specific. So some of the ones that we've actually defined, we developed technical briefs on these, and they're available on our website in different languages. So they're available in English, French, Spanish, and Russian. We developed frameworks, mini guides on minors, on children under 5 years old, on mobile populations, people who use drugs, prisoners, rural populations, and urban slum dwellers. And we have 2 more coming out on healthcare workers and people living with HIV. But of course, what we're really trying to do is develop a framework and a tool to estimate the size and burden of TB in key populations without defining those populations. So we're looking at countries where, in some countries, it could be that it's indigenous and tribal peoples who are the key population because of their lack of access or biological factors or geographic factors. In some places, for example, the Philippines, where it's a lot of islands and a lot of fishing, fishermen are not someone you think of as a key population, but in this context, they are. And when I was in the Philippines, some of the men who go out on the boats, one told me that in 20 years, he's had TB 6 times. Each time it got worse till it became multi-drug resistant TB and he could no longer work. So these are some of the factors that we need to take into consideration now. In your country, what would be your specific population that needs more tailored and specific interventions? So this is just an example of what some of the guides look like at the end, where we actually put in recommendations and some interventions for civil society, the people affected, governments, and the donor community. And these are by no means comprehensive, but they're to give you an idea of the types of things that can be done so that you can make them specific in your context. So in human rights, what we're working on is developing a legal environment assessment tool with UNDP. We're also, part of our strategy is to conduct judicial workshops where we bring together lawyers and judges, people affected, and programs and donors to really get them to understand what the TB human rights issues are, what cases might look like, and what are some of the human rights abuses that people face on a daily basis. And we're doing this in collaboration with Kalin in Kenya and the University of Chicago, the International Human Rights Law Clinic. So we're also developing a TB case compendium. As some of you might know, in HIV, when we had that compendium, it worked really well because we understood what some of the cases were, what some of the precedents were, and so we're trying to look at that for TB as well so that we can help judges and lawyers when they have cases come to them and they might not have had exposure to TB to try and understand what some of the case law is. So the Legal Environment Assessment Tool builds national capacity to facilitate an inclusive and participatory process for developing a human rights framework for TB and reviewing national laws and policies to align them with this framework. It plays an important role in identifying multiple contextual issues impacting access to diagnosis, treatment, and care for those who are most vulnerable to TB. And it aims to identify and examine all the important legal and human rights issues affecting people in a country. And this is really important to have this tool because now that the Global Fund has announced their new windows next year, 3 new windows for funding, this is an opportunity for us to actually get a legal environment assessment conducted under these grants. This is allowed because under the new Global Fund strategy, one of the components is all about human rights. So this is our opportunity to advocate for these tools to be implemented, not just implemented, because there's no use to have a lovely report that goes nowhere, but to have a report where they actually set aside money in the budget to be able to implement the recommendations. We also developed a TB/HIV gender assessment tool with UNAIDS. It's now been conducted in Lesotho, Niger, and Namibia, and together with the Global Fund, we're looking at least 4 more countries this year. This is also available on our website in a few languages. What we're going to look at is, as soon as we have a few of the reports back from these assessments, is to look at across the board, what were some of the interventions that worked? What were some of the gender-sensitive or gender-transformative interventions that were recommended? And how can we develop something where everybody would be able to at least have some idea of the specific interventions? And we also want to raise awareness that gender in TB is women and girls, men and boys. It is not one or the other, it's all of them in TB. This is just the purpose of a gender assessment, really to provide data. At the moment, we don't even have sex and age disaggregated data for tuberculosis at any level. It's collected. I go to the facilities, I see it in the report, in people's files, but it's not actually aggregated up into the subnational or national levels. And so we're at a disadvantage already by not knowing this, because we know that in some places we have 60% of men who are notified with TB, 40% women. We need to know why that is. Is it biological factors? Is it cultural factors that do not enable women to go or not? Is it because men can't get to a TB facility in the times that they're open? Thank you so much.
Thank you, Colleen. That was insightful, and thank you for sticking to the time schedule. I'm glad to introduce Mike Frick. He's our second speaker. Mike is someone that everybody should know because he's the author of the R&D report that you've seen, and I hope you have a copy already and that maybe you read it. The R&D report is available over there for those who didn't have it. But Mike is a senior project officer at Treatment Action Group, and he heads there the advocacy to support TB prevention research, including research to develop new TB vaccines and preventive therapies. He coordinates the Community Research Advisory Group, known as CRAG, and the Community Advisory Board to the US CDC's Tuberculosis Trials Consortium. He also leads the resource tracking activities for TAG annual report that already I mentioned, and he particularly interested in the intersection between human rights and TB research. To you, Mike. Thank you.
All right, well, thanks a lot for having me. I think this is the first human rights session that has ever taken place in an arena, so it's an interesting environment to be in. I want to talk about human rights and TB prevention. I think there are obviously manifold human rights issues in the TB response, and hopefully my other colleagues are going to touch on other parts of them. Certainly MDR TB, even drug-sensitive TB raises a lot of human rights considerations and dilemmas, but one thing we haven't spent a lot of time talking about is TB prevention in the context of human rights, and so that's what I want to focus on today. And this isn't meant to be exhaustive or conclusive. We're just starting to think about human rights in the context of prevention, and so I'm trying to raise questions today and hopefully generate ideas and discussion that we can take forward together. So I wanted to start by just reflecting on the place of TB prevention within our global agendas, because you kind of have to look between the lines to find it. It's not always spelled out so clearly. We have these set of 90-90-90 targets from UNAIDS and the Stop TB Partnership that have set the really aspirational goals that we're all striving for. The UNAIDS 90-90-90 is, of course, focused mostly on HIV diagnosis and treatment. Of course, we know that an HIV treatment is prevention, so it's not as though prevention has been left out of this agenda entirely, but it's certainly not named and it's not at the forefront of it. In the Stop TB Partnership's 90-90-90, preventive therapy does show up under the first 90% of all people with TB placed on appropriate therapy. But again, prevention isn't named as one of the central elements that we're driving for. You kind of have to squint to see it. So that's why I'm glad that we're focusing on prevention increasingly at the conference this year and in today's session. So there are basically two things that I want to talk about today. The first is access to existing interventions for TB prevention, and here I'm going to be talking mostly about a right to health framework, drawing on the International Covenant of Economic, Social, and Cultural Rights. And the second thing is meeting unmet prevention needs through research and development of new technologies. And here I'm going to focus mostly on the right to enjoy the benefits of scientific progress and its applications. Not that these rights and issues can't have some kind of crosstalk between one another, but this is sort of a nice way to divide them for now. So in terms of access and the right to health, I hope that we're all familiar with Article 12 of the International Covenant on Economic, Social, and Cultural Rights. Colleen did a really nice job introducing it. It says that the right to enjoy the highest attainable standard of physical and mental health charges states parties that have signed and ratified the convention to focus on the prevention, treatment, and control of diseases, and to create the conditions that would assure medical service and medical attention to all who need it. Importantly, for our context, the right to health isn't a right to be healthy, and it's not just confined to discussions of health care, but it encompasses the provision of conditions that are conducive to a healthy life, and in all of its forms and elements, it must contain the four elements that Colleen introduced, that health goods and services need to be acceptable, available, accessible, and of high quality to the people who need them. So with this background in mind, I want to just walk through some of the complex human rights considerations that TB prevention presents us with. The first is the recognition that most persons with MTB infection will consider themselves to be perfectly healthy. And this is a huge number of people. We know that we have revised estimates for LTBI incidence globally. We estimate that a quarter of the world's population now has MTB infection, but most of these people don't know it. And if they do, they're of course asymptomatic by definition of what LTBI is, and therefore don't consider themselves to be sick. They may not, once they know about their infection, if they do and are diagnosed, consider themselves to be at risk. And in fact, only 10% of people with MTB infection will go on to develop active, symptomatic, transmissible disease at some point in their lives. So for any particular individual, diagnosis of TB infection and then the proposition of treating that infection is something that isn't necessarily backed by a high perception that they themselves are at a large degree of risk. But we know that some people are at more risk than others and are more vulnerable to disease progression, including people with HIV, those with other comorbidities, and some categories of people, including pregnant women. So the risk consideration changes, and it's important to think about whether in TB prevention diagnosis we're doing an adequate job of counseling people about what MTB infection really means, what the risk is for that person over their life course, how it could change as they age or go through various life stages. At the same time, this kind of counseling and education is difficult for us to do because aside from saying that there are some correlations between progression to disease and categories like having HIV or not, being pregnant or not, aging or not, it's not possible for us to reliably predict who with LTBI is likely to progress from infection to disease. We lack a good prognostic test. And so in the absence of adequate technology, the job of messaging MTB infection to those with it becomes increasingly difficult. At the same time, basic science research into the nature of TB infection is teaching us that TB infection is actually a spectrum of activity and risk. So we used to have this idea that it was a kind of bifurcated state. You either had latent infection or active disease, and these things flipped one into the other, but they didn't have a lot of continuity between them. Research in preclinical animal models and some data from human studies has now dispelled us of that notion. It's not either or. There's a continuum of activity that underlies infection to active disease. So tackling latent TB infection is going to ask us to think about a whole new clinical category of people, those who are pre-symptomatically ill and may never become ill. And where we decide to intervene on this spectrum of risk is going to shape the number of mostly healthy people who are asked to undergo testing and treatment. Of course, we haven't decided where to intervene on the spectrum of risk because we don't entirely understand it yet, and we lack the ability to reliably predict who's going to progress from infection to disease. So this is still an unmet scientific question that we're going to have to tackle, but I think it has human rights implications as well, because it's going to define the number of people and the type of people who are opened up to what may be an unfamiliar form of medical intervention. The idea that they have to undergo treatment for something that isn't making them feel sick or undergo vaccination for something they didn't know that they had. And so decisions about who we test and who we treat should be guided by rights-based approaches, recognizing the limitations of the science before us. And I think we shouldn't be surprised if in increasing TB preventive services, as we're trying to do under the NTB strategy and the Stop TB Partnerships Global Plan, we're met with a lot of skepticism or even refusal on the part of communities. And in my mind, the skepticism isn't totally unwarranted, right? In many places, a TB diagnosis still carries a lot of stigma. And there are countries in the world and even local contexts and municipalities where TB infection, disease, transmission, or all of the above are criminalized or poorly approached under the law. At the same time, TB is a disease of close-knit communities and families, so a TB diagnosis isn't just an individual consideration, it's also going to impact a household and a community, and we have to remember that when we diagnose someone with MTB infection, we're likely also making some sort of comment about the contact that they've had with people with active disease, and this has implications for the people that are going to be around them. So I think perhaps thinking of indicators of how we know that we've hit the right balance with a rights-based approach to TB prevention, I just want to propose the following two questions that can guide us in our thinking. I think we'll know that we've gotten the balance of rights correct if we can get to the point where people diagnosed with active TB request contact tracing and screening of family and friends. Right now, this request isn't usually made. It's a fraught proposition to bring healthcare workers into the household if you have a TB diagnosis, alerting your neighbors, scaring your family. And what do we have to offer these people? Poorly predictive tests like TST and IGRA, preventive therapy that is long in duration and carries toxicities. In the case of MDR TB exposure, no recommended preventive therapy at all. So we can get to the point where contact tracing and screening of family and friends is requested by the person with TB disease. I think we've gotten to a point where we know that we've combated stigma, reduced discrimination, done adequate counseling, and gotten our messages right. At the same point, if we can get to a place where people with HIV demand preventive therapy as their right, where parents with TB disease demand it for their children who may be infected and exposed, then we've also gotten the balance of rights correct. And right now, we all know the struggles of scaling up preventive therapy globally. Very few countries are doing it at large scale, with the exception of perhaps South Africa. So we certainly have our work cut out for us in this way as well. I put up the TB Proof logo here, or one of their images, because I think that this group, and some of them are in the audience today, has hit upon a really ingenious way of talking about TB prevention. You know, we've always talked about LTBI, which is a kind of misleading term because it tells us that it's not a problem in the name, you know, with this word latent included in the title. And there's been an encouragement to shift to talking about TB prevention or TB infection instead of LTBI. But what TB Proof has done in my mind is take it one step further and talk about prevention in a way that is intuitive, appealing, and makes sense to the people that it applies to, which is not just preventing TB, but making yourself TB proof. And I think we need more of these kind of strategies if we want to take TB prevention to a much wider scale. And we also have to get to a point where what we have to offer people is improved over what we have today. So I've just taken the WHO guidelines on LTBI, the table comparing the various regimens that they recommend, combinations of rifapentine and rifampicin with isoniazid, compared to 6 months of isoniazid, the standard of care. They recommend all these regimens, but what I want to point out in this particular slide is that everything here carries toxicities, particularly to the liver. And so if we're trying to do treatment of TB infection among people who consider themselves to be healthy, may have a low risk of disease progression, may not consider themselves to be at risk, and may not want to interrupt their life by taking a long, difficult course of therapy, we also have to remember that the therapies we have to offer are not entirely safe either. So this brings me to the second point that I wanted to talk about today, which is meeting unmet research needs in order to have a rights-based response to TB prevention. And here we're working under Article 15 of the International Covenant on Economic, Social, and Cultural Rights, which is the right to enjoy the benefits of scientific progress and its applications. Article 15, which is less well known than Article 12 on the right to health, is, I think, a really powerful and transformative piece of international human rights law that we should be referring to more often. It basically says that scientific progress isn't just general knowledge advancement, but it extends to the actual applications of that discovery, tangible benefits, which in medicine is things like tools such as diagnostics, vaccines, new drugs. All people are entitled to enjoy the right, and the human rights principle of non-discrimination applies here as well. And states, when they fulfill their obligations under scientific progress, have to pay particular attention to vulnerable and marginalized groups. And they have to do two things in this regard. They have to develop science, and they have to diffuse it. So I want to reflect a little bit on how innovation, research, scientific progress, when grounded in human rights in this way, can be a powerful catalyst for activism and activity. We're seeing this play out in HIV prevention already, where the advent of pre-exposure prophylaxis, Truvada, has inspired a resurgence in HIV prevention advocacy. This has included some controversy. Communities that are not used to thinking of biomedical prevention interventions, aside from condoms, having really tough conversations with themselves about how emerging HIV prevention technologies satisfy that AAAQ framework that Colleen introduced, particularly around issues of acceptability. At the same time, I think that pre-exposure prophylaxis and treatment as prevention in the HIV world has mapped us a way to sort of get around this long-standing debate of treatment versus prevention, and that has been useful from a rights perspective because it allows us to not sort of falsely divide the two any longer. But as you can see from the image of UK activists protesting and encouraging the National Health Service to list PrEP on its formularies and coverage charts, access remains a barrier. Innovation is also inspiring activism in TB prevention, even though I think we're a little slower than the HIV side in terms of the output of our research. The particular product here is rifapentine, which when combined with isoniazid forms the 3-HP regimen, cutting the duration of TB infection treatment to just 12 once-weekly doses of these drugs in combination. US activists, after rifapentine was approved, realized that the price was too high for public health programs in the US to actually use the drug. And this resulted in a year-long pricing campaign against the manufacturer of rifapentine, the pharmaceutical company Sanofi, to lower the price, something that they eventually did. Once that price was lowered in the United States, programs began to use it more often, and the other pieces of global access for rifapentine began to fall into place. It was approved by a stringent regulatory authority, the FDA, in 2014. The WHO added it to its model list of essential medicines for adults and children. It was included in the WHO guidelines that I showed you earlier, listed on the catalog of the Global Drug Facility, now at affordable price in the US, and it's the subject of ongoing research. So all of this sounds quite good, but at the same time, there's a major piece of rifapentine access that remains pending, which is in-country registration in countries other than the United States, and that hasn't happened yet. So the same battle that was being fought by activists in the UK to access PrEP is, I think, going to need to be fought in countries around the world that want to use 3-HP and improved LTBI treatment regimens. This is a slide that I don't expect you to read in detail, but it shows you the major ongoing TB prevention chemoprophylaxis studies that are either already underway or planned. And the thing that I want to point out about this slide is that rifapentine is occupying the center of the TB prevention research agenda when it comes to chemoprophylaxis. It is being studied in these 5 trials that are circled here. So nearly all of the major studies for TB prevention are depending on rifapentine. We have to get the access story for this product right in order to ensure that development is met by diffusion, that both parts of the right to scientific progress are satisfied, and that we can begin to offer people with TB infection a shorter, safer, better tolerated regimen than isoniazid. So that's where I want to end for today, and I'm looking forward to the discussion, and we'll turn it back to the chair.
Thank you, Mike. This has been fantastic. And I'm happy that you offer this kind of presentation to an audience like ours today, because I think that some of the rights, especially the right to scientific progress, is something that people don't know much about. So without further ado, I'm going to pass the mic to my friend Jonathan Stillo. What better than a medical anthropologist to walk us through the path of patients' rights, especially that Jonathan has worked in Romania, and he has been someone who observed the field more than anyone else, especially the field of TB and Romanian sanatorium. So Jonathan is an instructor of medical anthropology at Wayne State University. He's also a doctoral candidate in anthropology at the City University of New York. And he is also a Fulbright grantee and also grantee of the U.S. National Science Foundation. I can go on and on and on, but I'd better listen to you, Jonathan, so go ahead.
Thank you, Zaid. So I'll start in the beginning saying how I arrived here. I started out doing research, and I never planned on becoming involved in advocacy. And I went to Romania looking at tuberculosis, and what I thought I would look at was poverty. Because everyone I spoke to said, well, the real problem here is the poverty. This is what's the problem. You know, everything is fine. It's poverty, it's alcoholism. And what I saw actually was not that at all. There were a lot of issues around access and things like that. So as a medical anthropologist, I had a number of field sites, but the most important one was that sanatorium on top of the mountain there, which is where I lived for several months. In the past 10 years, I've lived in Romania for about 5 of them. I've interviewed hundreds of patients, dozens of doctors. I was part of the World Health Organization mission there. But I should state that anything I say today is not endorsed and the opinion of WHO. These are my personal opinions. So I started out by interviewing and surveying all of the patients at the sanatorium. And I had this fantastic idea that I would do a follow-up project the next year. And I would return, interview the patients that I had known, visit their homes and villages. So the next year I go back, and nearly all of the drug-resistant patients were already dead. Those who were not dead had developed additional resistance. So there was no one to follow up with. There were no villages to go to. It was just me at the sanatorium wondering why everyone was dying, why everyone was not becoming cured, even though they were being treated, and why everyone was developing drug resistance. So this is how I arrived here, and I decided that I'm still a researcher, but if I don't do something with my research to actually help people survive, then what are we doing here? So the purpose of this presentation is not to throw Romania under the bus, and in fact, I think the Romanians are really brave, especially because they've allowed me to be there and do this research, and there's a lot of openness. But what I'm going to talk about are what I've been referring to as the dark ages of the Romanian tuberculosis program. For a lot of reasons, funding reasons, political reasons, Romania was unable to meet the needs of the patients in terms of diagnosis, in terms of treatment, in terms of any form of support whatsoever. And this hurt the poorest and most vulnerable patients the most. So what we're talking about is self-administered treatment in rural areas, and 45% of the population lives in rural areas. And we're not talking about an impoverished country. And I think this is something that we need to be thinking of. And Colleen mentioned accountability. And accountability is really what we need to be demanding. Because where are people with dying of TB? They're dying in middle-income countries. They're dying in countries which have airports, space programs. There is money. These countries have the money, and Romania is one of these, but the money is not distributed and health is not prioritized. And one of the things that I want to stress is that we don't pay enough attention to the promises that these countries make. And the International Covenant for Economic, Social, and Cultural Rights is something that many of the countries of the world have signed on to, and certainly nearly all of the European countries have. This is not new. It might sound new because Stop TB is developing an assessment tool, but these treaties date back to the 60s and 70s, so we should really be ashamed of ourselves that we're just now finally starting to systematize thinking about rights and holding people accountable. So, as I said, these kinds of conditions are awful, but they're not just in Romania. In fact, these are the same sorts of things we're hearing from national TB programs from all over the world. So we really need to be looking at what are the promises versus what are the actual conditions and what are causing these patients to die. In Romania, over 1,000 people are dying of TB every year. This is not a very large country. This is a lot of TB. And every single one of these deaths, so 1.8 million deaths in every year, is a stupid death. This is something that Paul Farmer talks about. These are deaths which are preventable. There's no reason why anyone should die of tuberculosis. It's curable. It's curable up until the very late stages. It's curable when you have holes in your lungs like this. And we've seen that happen once people have access to good treatment. So some of the specific human rights-based concerns that we raised as part of the WHO review are related to diagnosis, and this is something that we've been talking a bit about. We found variations, massive variations in access to diagnosis. In one county we visited, only 10% of the patients had DST results. Now, if you're wondering how I could be living at a tuberculosis sanatorium where everyone is taking pills and living there under treatment, but not getting better, this is part of your answer. We're treating without knowing if the drugs are working. Personally, I can't imagine being subjected to that, taking drugs for months, and then finally finding out that they don't work. I met one young woman on that visit. She had been hospitalized for 9 months. She was poor, she was from a village in the north of the country, and she found out she had TB when she got pregnant. She was hospitalized, treated for drug-sensitive TB. It wasn't working. Then she was transferred into an MDR section, treated for MDR TB. It wasn't working because she had XDR TB. Because access to diagnosis was so bad and so slow, using solid media and not doing everything at once, but waiting and waiting, this woman lost 9 months of her life, all the while taking awful drugs which make you deaf, which give you horrible side effects. So this was the norm in the period that I was living there, and it's a human rights violation, plain and simple. We also found a threefold difference between patients who were treated in the Global Fund project and patients who were treated in the state-funded project. There's no explanation for this. As much as I love the Global Fund, I think this was a real travesty because the Romanian state was unable to provide correct treatment. Patients were receiving 2, 3 drugs. Second-line injectable drugs were virtually unavailable in the years that I was living in the country outside of that Global Fund project. The problem is that the Global Fund could only treat about 20% of the MDR patients. Everyone else was dying. And as I had it on the previous slide, treatment success rates in this period, 2009 through 2011, were bouncing between 16 and 20%. These are some of the lowest rates you can find in the entire world. And then finally, what we found was that the poorest patients were the ones with the least access. So there were 2 Global Fund treatment sites, and a lot of the patients came from rural areas, and they were unable to access them. So a patient is diagnosed with MDR TB, and the doctor says, you can be treated at one of these sites, but you'll have to submit to hospitalization, 6 months, you'll have to be away from your family, and during those years, there was no economic support whatsoever. So how could we ask someone who's poor, who's struggling to feed their family already, go move 300 kilometers away from your family so you can receive the only treatment which can cure you? It's unconscionable. And then finally, patients who had XDR-TB had no options whatsoever. Those who could afford it were buying linezolid on the internet, patients were exchanging it, but the country was not able to provide any kind of treatment. So again, what was happening was people were dying. So this is the last picture ever taken of Florian. He was a 21-year-old, really boy that I met at the sanatorium. His father, the slide says he had MDR-TB, but eventually he was tested and he had XDR-TB. So this boy is hospitalized, lives in the sanatorium, and he was a city kid. He was so out of place there, and he was really lost and having a hard time. When he finally finds out he has MDR-TB, it's 2 months after he's been living in this awful place. The day he found out, and actually the day that I interviewed him, he went home and he killed himself. There was no reason for it. I think this is maybe the stupidest death of all. Had he been properly diagnosed, had he been properly treated, this would not have been an issue. And there was no psychological support, no means to let this kid know, your father is dying, your father has really advanced disease, but you're young, you're gonna be fine, we can do this. So I think this was one of the gravest failures. And I'm happy to say that Romania has greatly increased the availability of psychological support in recent years. The next patient I want to talk about is Julian. I only knew Florian for a day. I knew Julian for years. This is a person who I became friends with, a person who's I'm still close with his family. And this is me several years ago at a TB managers meeting in Europe, basically challenging the NTPs. Could you cure someone like this? Everyone is always so proud of their treatment success rates and touting the good statistics, but we don't even have a means of assessing whether programs are able to reach the most challenging patients, patients who need a little bit extra. This was a patient who needed a little bit extra. He was very poor. He was Roma, which is a community which has very little access to healthcare, hated within Romania. But he was a great patient. The doctor said he was the most conscientious, the most dedicated, but he couldn't afford to leave his family. He would run away from the sanatorium because his family needed money. They were really struggling. They were living on the social welfare payments that they got from the mayor's office were about $30 a month. This is not enough to feed your family. So he died 4 years ago. And the question that I always ask is, could we cure him today? Do we have the conditions in any of the countries that we work in to reach a patient like this? A patient who wants to be cured, but who can't be. Not because it's his fault, but because the health system is not serving him. And what I heard from the colleagues from Papua New Guinea the other day, I think was really important. They said, what we do is we try to force the patient into the system. And instead, what we need to be doing is making the system fit the patient. We talk a lot about patient-centered care, people-centered care. These are just words. We don't do this. The way TB programs look today fits what the doctors, what the nurses want, what the system wants, but they do not serve the patients. And that does not respect human rights. So, right now in Romania, there is some good news to report. There is very fragile progress. The Norwegian Development Program has stepped in, and they are buying the drugs and providing all kinds of other support to fill that gap that was left from what the Global Fund was covering and what the state was not. And this is amazing. People are getting cured. Things are going better. However, this is unsustainable and will not be lasting much longer. So I can say that for the moment, things are good, but if we look at the past precedent, I think we should be very, very worried. And some of my heroes in the back of the room are from the Romanian Patients Organization, and they're fighting hard to make sure that we don't end up back at this point. But if the government does not take control of this, then I think there's a real danger that we will return to the days of drug stockouts and patients just dying every day. So I've talked about these, talked about the patients and I've talked about the programs, and what I want to talk about very briefly is, well, what is the context? And one of the things that shocked me the most, as an anthropologist, it was not my job to know the laws and the legal frameworks. And what I found was that, there are all sorts of laws which protect these patients. There are all sorts of treaties which the countries that we work in have signed, but yet they don't respect. And we don't hold them accountable. And I think one of the most challenging things is that the context in every country is different. And one of the things that we find is that, well, who is writing the human rights section of WHO reviews? Oftentimes, it's a community member who is asked at the very last minute, who's very well-meaning, who wants to help, but they're not a human rights lawyer. They're not an expert. They're somebody who knows about the community, but this is not their job. We don't send a community member who's never been in a laboratory to write the laboratory section of these reports. So why do we tolerate having people who don't have this expertise producing these reports, which, and I've read a lot of them, tend to be profoundly vague? There's a universal right to health, blah, 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 scientific progress. These are meaningless words. However, a lot of these countries have legal commitments and there are requirements, and we have to hold them accountable. So, as I said, Universal Declaration of Human Rights, not enforceable. However, the International Covenant on Economic, Social, and Cultural Rights is, and we really need to start taking this seriously. So very briefly, I'm not going to read through all this, there are 4 dimensions of accessibility. And if you think about the people who I told you about who died of TB, were we able to meet those points? Non-discrimination, physical accessibility. In rural areas, the answer is no. All over the world, we are poorly serving people in rural communities, and they're dying of TB. They're dying not even knowing whether they had MDR or XDR. It doesn't matter anyway. They're dead. They didn't have access to good care or treatment. Okay, so finally, I want to talk a bit about this right to information accessibility, which is part of that. And this applies to knowing your DST status. Now, we're hearing from programs at this meeting which don't even have access to smear microscopy in areas. In Romania, as I said, we had stockouts of solid media. Patients were not receiving DST, yet we were forcing them to live in hospitals for months. People need to be able to know, what do I need to become cured? And we can follow on that with knowing about whether we have latent TB or not, which is really important. If you've been exposed to TB, you should have a right to treatment, and that's something that we are just starting to think about, and it's going to take a lot of work to further that. So finally, I have a couple suggestions, demands, because I'm really tired of talking about people dying of TB, and every year it seems to get worse. We want to insist that programs respect the full meaning of human rights. Human rights is not just non-discrimination, it's not just trainings about ending stigma. This is not human rights. This is a fragment of what human rights are. Human rights is a really large concept, and it has a lot to do with access to health, access to diagnosis, technical things. So we need to treat it like a technical question. And it's something that legally countries are required to provide. So stop just paying lip service to human rights. Let's start talking about it in a meaningful way. And finally, a lot of this has to do with access to data. National TB programs treat data as if it's a state secret. This is ridiculous. I'm a researcher. There could be millions of me doing this kind of work. If data was available, we need to be posting it, and we need to be holding programs accountable. How do we know that a program is reaching the poorest, the most vulnerable people? We ask them, and they say they are. And then it takes an overworked, underfunded community organization to do the research to find out that they are failing miserably. It should be flipped. They should have to prove that they're reaching the most vulnerable people. That's how you respect human rights. Thank you very much.
Thank you, Jonathan. Very inspiring. I happened to be in New York last week where there was a reception celebrating the 50th anniversary of the Covenants. And guess who was celebrating? Basically, representatives from high-burden countries where they're just talking about the achievements that they happen. And if you're just there, you feel like we already reached that level of applications of those rights. But thank you for highlighting that. If you didn't, realize, I'm looking at my panelists and I'm seeing that basically we respected gender balance. We respected somehow regional balance. I'm from the Eastern Mediterranean region. My colleague was talking about Eastern Europe. The Americas were here. And now...
I'm African.
Oh, but
I just
based
sound
in
American.
Geneva,
Yeah.
I think it doesn't, that's it. But anyway, I am really happy to introduce my sister, who's actually representing the whole Southern Hemisphere. She is, one of those activists that you meet once and you will remember for a long time. She's the one who inspires people. Lynette Mabote works with marginal groups. She is a lawyer by training, but activist at heart. So I'm not going to take more of her time. I'm going to offer her all the space she wants because she's such an inspiring speaker.
Good morning, everyone. Just to say that, I don't know what's happening. Technology and me, we're never friends. Just to say that there may seem to be a few of us in this room, but I see a lot of ancestors of patients who've died in this room to join us in this fight. So we may not have a full room because we're not so-called scientists and We're not talking p-values, although I've never really understood what a p-value is because I'm just a legal brain. But I'm very excited to be here with you at this conference and to be talking about this topic that, of course, is the only one within the whole conference. Apparently, there was also a workshop. But it really is atrocious that it took Zeed a lot of effort and threatening of certain people to get us this session, and the fact that nobody has the response or the respect to even attend it. But moving on, and I will stop complaining now. My name is Genelo Lynette Mabote, and I am from, as he said, Southern Africa. I work for an organization called the AIDS and Rights Alliance of Southern Africa. I think the panelists have laid out the groundwork really well in terms of where the challenges are and how we can start moving these forward. But I want to bring the conversation back to, number one, who do we hold accountable? I don't think we can blame the Global Fund. I don't think we can blame the PEPFAR. I don't think we can blame WHO. I think the blame needs to start at home. It needs to start with our leaders. It needs to start with the health system, because what we are currently looking at is we're heading for a genocide. And as my colleague Enrique spoke yesterday very passionately, why does it have to get to that stage for people to wake up? And what do we need to do to preempt that? And this is why we're talking about prevention, I think, at this session, which is quite critical. As I said, I'm not a scientist. I'm a lawyer. And this is really something that really freaks me out. TB killed the mummy, right, before Christ. TB killed the mummy. Yet today, we're still sitting with a tailored time bomb, right? And Jonathan Usman said in 1985 that we are transforming an eminently treatable infection into a life-threatening disease that is exorbitantly expensive to treat, and a rigorous multinational response is needed. This was in 1985, and we're still saying the same thing. So at this point in time, we should know what our epidemic is. We should know where to target our interventions. We should know who to invest in. Science has shown us how to do it, when to do it, but we're still not doing. Why? Sorry, I just like putting my heroes up because this is a consolidated package and because I love cartoons. And I think we're all heroes, of course, so I always have to throw it in there somewhere. I think the reason why this public health disaster is now really turning into a human rights catastrophe is because we are facing the stuff that I've underlined in red, right? We've got a lack of infection control, irrational first-line treatment, and of course, interruptions that never end. We have now gotten to a point to say, okay, we need to disaggregate data, we need to find most at risk or key populations, and we need to find them for these reasons, all right? We've articulated the reasons really well in that we know where TB thrives, we know because of stigma and discrimination, we know that there's limited healthcare services, we know that we're facing a lot of legal, political, religious, and socio-economic backlash, as well as hostility towards treating people as humans. Women and TB, as we've said, are also a very key population. And we know that we treat people like rats in a cage. This is what most prisons look like in the Southern African district. This is a picture of a prison in Malawi where prisoners are expected to sip, sleep, and live on top of one another. So if we're talking about high burden settings, then we really are talking of disaster forming. And if we're looking at what stays in prison doesn't stay, what happens in prison doesn't stay in prison, if we believe in that principle, then we really need to have strong prevention interventions, as we said. So our health minister, who's really been a good champion, and this is where I go into the part where I start speaking more about the work that our organization has done, said in 2010 that if tuberculosis is a snake in Southern Africa, the head of the snake is here in South Africa. People come from all over the Southern African development community to work in our mines and export TB along with their earnings. If we want to kill a snake, we need to hit it on its head. Okay, so this is a key population that we started working with as the AIDS and Rights Alliance of Southern Africa, realizing that the mining industry has abused people's rights since the 1900s. It got to a point where so many ex-miners were dying of MDR-TB as well as XDR-TB in the early 2000s, and governments were not putting policies in place to protect this key population. It is atrocious that we had to face this, but I mean, at a regional level, it was a cross-border issue. It wasn't necessarily something that only took place in South Africa. So as colleagues such as Section 27 and TAC and so forth have taken the mining industry as well as the South African government to court to get these rights approved and to get the mining industry to basically acknowledge the fact that there is an occupational health safety around tuberculosis in the mining industry, and for the South African government to take responsibility and acknowledge the fact that they were the ones that caused this. That is one of the cases that basically shows us that it is critical to do it. At a regional level, it's not easy to sue cross-regionally, right, because of sovereignty. So we have started taking these cases and talking about taking these cases as well in countries such as Swaziland, in countries such as Zimbabwe, as well as in countries such as Mozambique, an example that it can be done. And actually going back to this case, colleagues in South Africa have been successful in lodging this claim in a class action, looking at 1,500 ex-miners. So we need more class actions like this because it has been proven that it can be done, right? The only thing that we need to figure out around tuberculosis and around the other cases is what does a TB-related legal matter look like? And that is going to be something that I come to next in my presentation. So we're looking at a case of course, the discrimination and the stigma, calling people suspects and so forth. I think we've heard it a lot at this conference. We've tried the naming and shaming, of course, looking at the judiciary and bringing this naming and shaming back into context. There has also been a court case where you got people who've been in prison for a weekend, for instance, for a small infraction, and these people leaving the prison setting with tuberculosis. And this is where the shame needs to come from. So that little girl, of course, was arrested for stealing something in a Malawian prison, but they could not even prove that she had stolen something. She was there for 6 months. She came out and she had tuberculosis of the prison cell. So these are the types of cases that we've started taking on at a domestic level to promote this agenda. But what we started seeing when we started taking these cases to court was what Colleen was mentioning, the fact that a lot of the judiciary didn't know what a TB-related legal matter looked like. They didn't know, they didn't have a point of reference. So as judges, it's not that they don't want to work with us in holding states accountable, they don't know how. So the work that Chicago Stop TB Partnership and Kellen are doing is really strengthening the judiciary to be that strong arm to do a lot of this work. Colleagues have spoken how we do articulate a rights-based response to tuberculosis, right? And we've spoken about the fact that we're facing these draconian public health laws which are really coupled with clinical biomedical interventions but fail to detect what is missing. Right, we're facing a lot of human rights violations on people who already have been diagnosed and who already, for instance, should be receiving rights-based care. So this includes forced involuntary treatment. There are cases of people who, for instance, once they've been diagnosed and are told that, for instance, they've got multi-drug resistant tuberculosis, are not even afforded the opportunity to, number one, contact their families to tell them that this is happening, this is how long I'm going to be away from. Number two, employment is lost. Number three, the fact that nobody explains what's going to happen to you in that period of so-called isolation or incarceration, as we call it. The hospitalization as well speaks to that. Isolation and detention, they don't follow the Syracuse principles that I'm coming to now. And clearly there is a very fine balance between this public health good and the violation of rights. And of course, governments are justifying this as controlling TB. Meanwhile, it's just really controlling human beings. It's getting rid of human beings, really, it is in a sense. So as I said, we have been given global guidance in terms of how to do some of the work, how to articulate some of the human rights interventions, following, for instance, frameworks such as the Syracuse principles, which really should be used as a yardstick whenever, for instance, you're dealing with multi-drug resistant tuberculosis and how you go about so-called isolating patients. In countries like Botswana, what was happening and what continues to happen is patients are also running away from the hospital when they've got MDR tuberculosis, because once you've been there for 4 months not knowing what's going on, your body wreaking havoc on you, I'm telling you, you will escape, right? It does really feel like imprisonment. So when we visited hospitals to find out what it is that they're trying to do, because we've seen that the patients are ending up in prison cells, they say to us, well, the patients run away, so what we do is that we send the police after them. So, and then the police isolate them in a jail cell. I'm like, wow, okay, so, and that is a practice that is now, for instance, is it a practice that seems to be working? No, it's not necessarily about that individual, right? Because public health dictates that you can sacrifice the few for the majority, but it's not really even yielding, and that argument is not receiving the so-called much claim that it presupposes. So, as I said, we're facing all of these, and the coercive strategies that are being used by a lot of the countries are leading to high levels of stigma that are perpetrated against communities and as well as at the healthcare facility, the loss of earnings. We're seeing poor working conditions because of this TB transmission rates. And we're seeing that in some cases of employment, people who have had TB diagnosis or history of tuberculosis really aren't even getting employment opportunities. So if you've had TB, some employers just don't hire you. And that in and of itself is a violation of human rights, right? And that is a very big issue that we can really start looking at as low-hanging fruits, right? The travel restrictions that we've seen even coming to this conference are a very big stark matter that can be looked at in terms of litigation and how we can move this forward. I borrowed this slide from our colleague, Dr. Jennifer Furen, who's just a fierce doctor working on this work and now focusing a lot on multi-drug resistant tuberculosis. Her questions are really clear, and these are the questions that we should start forming a legal agenda around, right? So, is it stigma or is it just frank discrimination? What is it, right? The questions are, what can be done when physicians, nurses, and other providers refuse to see patients with tuberculosis? Is that a TB-related matter? Is there any legal recourse or means to protect persons with tuberculosis when they are fired from jobs, kicked out of their homes, and physically injured because of their disease? Can existing legal protection under disability law or hate crime law be applied to persons with tuberculosis? And how can this be done in countries that do not have existing legal frameworks? Now, just to say that HIV has got compendiums, there are lawyers on standby looking out for discrimination, looking out for HIV-related matters. They are taking so many governments to court that compendium that Colleen was referring to is turning into more than a Bible. It's really turning into something else, because patients' rights are human rights, and patients are tired in HIV. But our patients or our groupings aren't strong enough to promote or to push these legal matters. And the reason why they're not strong to push these legal matters is because, frankly, people don't know that their rights are being violated. If you are being told that you're supposed to follow a DOT system, you go to the healthcare facility because, of course, you want to get well, and you get told, come next week, there are no drugs. Do you know that your rights are being violated? No, you don't, right? So that is where we need to do a lot of the community mobilization, and that is where we need to do the communication. Because once we do that mobilization at that level, we really will start seeing these cases come up. As an organization, we're working with the Southern African Litigation Center to target 3 countries in SADC, where we're going to push for class actions on one issue in these countries, because everybody has suffered through the same issues. And in building this legal strategy, we want to see whether or not we can sue our Minister of Health around these issues. And in doing so, We want to see whether or not we can galvanize action in the rest of the region. And I encourage all of you colleagues to do the very same thing, because I'm sorry, somebody needs to pay. It's long time. We need to actually stop allowing deaths and allowing this genocide, because I think the trajectory that we're heading at, it's not going to be 10 million people anymore, according to these reports by organizations such as the WHO. We're really going to just face mass genocide. And I think it is high time we started holding someone accountable. And that someone that's accountable is someone at home. Thank you.
Mabote, ladies and gentlemen, that's, I think, where we are in terms of human rights activism. But I think it's important to realize that this is not the fight of just everyone who's on this stage, or even actually everyone in this room. I think it's everyone's fight. And I hope also, if the union is listening, that we don't only have human rights sessions within the union, but we invite human rights activists to be part of the different sessions that are going on. I mean, if I go through the different vulnerable groups you cited in your presentations, these are all groups that we are talking about in the union. We're talking about prisoners, but the human rights angle is not covered in those sessions, and I feel it's extremely important that human rights are plugged in, whether in the plenaries or in sessions that are tackling these groups, just so the people who should know about human rights can be in the room and can be sensitized to the issue and to their own, maybe, failure. So we have scheduled a Q&A session. Why don't we start with the first question, if there are any. I know we have 2 mics in the room, so excellent.
Hi. First of all, thank you so much for everyone's contributions. It's been a really, I think, a session that's been absent from the union so far in large regard. Some satellite sessions have touched on a lot of these issues, and it's really refreshing. So thank you to all the participants and speakers. It's been really, really nice to listen to you. Just a few comments. I'm Kwet Kotsa. I'm from TB Proof, South Africa. And just to run through, with regards to Mike, thanks for the plug for TB Proof. It was really nice. My concern with regards to the transmission prevention side, and I think this is a human rights issue, is my fear that we tend to have an overly biomedical focus when thinking about prevention of tuberculosis. And I think Lynette also touched upon that a bit. When we talk about prevention, we tend to think about vaccines, treatment of LTBI, and we think about medical ways of treating this. And to me, that's largely a failure of the imagination, especially from a human rights point of view, because we've got so much going on that drives the epidemic. I mean, that quote from Aaron Matsaledi is extremely illustrative. We talk about the mining industry driving tuberculosis, and there are so many things there beyond just treating tuberculosis. The conditions are absolutely appalling, and you can really extend that to so many things. In a way, I feel often with regard to tuberculosis, we are trying to deal with a mass issue. For example, if you had millions of car accidents leading to many injuries in a country, and we say our way of dealing with that is going to be to invest in more hospitals to treat the victims, as opposed to making our roads safer. So with TB, we really should be thinking more upstream. I really, really think we do need these biomedical interventions at all levels, and I really appreciate the work everyone does for that. But I would like to invite everyone here to think broader in terms of how we can prevent tuberculosis in a very upstream way, making our facilities safer, making our homes safer, making our environment safer, while still focusing on these other things. So thank you very much.
Thank you.
Hi, I'm Chanel. I'm also from TV Proof. I just had an idea that I'd like to extend to the panel members in the audience. You mentioned that you were going to include 2 new key populations, and you mentioned that HIV is one of them, and I was wondering if it would be a better idea to say immune suppression and then listing HIV, diabetes, people on immune suppressant therapy, because I think that's going to help a wider variety of people connect with TB.
Let me take a few and then.
Yeah,
Thanks,
we'll take
everybody, for their really stimulating talks, and thanks, Ziad, for the heavy lifting to get this organized. I agree with Lynette. I think it's a shame this wasn't done earlier and better, so it was actually printed in the conference booklet, and maybe more people would have known about it then. But aside from my editorializing, I had two questions for the panelists. Mike and Lynette, you both, well, Mike, you mentioned kind of the importance of generating actual demand for preventive services, and in this case, the biomedical ones. And Lynette also mentioned kind of the importance of the community mobilization. And I was just wondering how you think we can get to that kind of treatment and prevention literacy that we need to create that kind of demand to drive the implementation of these human rights. And then I had a second question for Jonathan, which is, just given the disparity that you've seen between Global Fund funded care and national funded care, what do you think that means as so many countries are about to transition out of Global Fund funding, and how can we do a better job of ensuring this? And do we need to be asking Global Fund to freeze transition? Do we need to put more accountability on countries? Just looking forward to hearing your thoughts on that.
Excellent. I think we have a round of 3 questions. Maybe you can add a 4th one, and then we give the floor to the panelists, and then we take another round of questions.
IOD. Okay, it's not a question for me, it's just a comment. On behalf of the union, my name is Norma Bondo. I'm with the union, the Civil Society Liaison Officer. Yes, Collins. Okay, I fully agree with you, Lynette, on the issue of judiciary. And I think where we are right now in terms of positioning HR within TB agenda, it's the same process that we followed with HIV. That is why, because I remember a long time ago when judiciaries and magistrates were not able, people were being discriminated, people were losing their jobs, but magistrates didn't have. There were no articles, there was no legal framework that could guide them to get to reach out those decisions. I personally was one of those victims because I lost my job when I was diagnosed HIV positive in 1997. But there was no legal framework and there was no law. And as much as your AIDS legal network were there, but still there was nothing concrete. And I think if we were to follow that path, again with TB, we will eventually get there. And as you've just raised the issue of, I will take this, your comment to the union, because tomorrow morning we are meeting the coordinating committee on scientific whatever, but it's the committee that organizes conferences to really build in HR topics within the program as we move forward, because it is. And personally, again, where I come from, in terms of identifying civil society that I need to work with, I did identify human rights activists, because everything, when it comes to public health, you cannot do away with human rights. Everything has to fit, human rights has to fit within each and every agenda of public health to be successful to combat the epidemic.
Thank you. Thank you. I'll start with Colleen on the issue of vulnerable groups. What do you have to say about that?
So thank you so much for raising that. We actually did think of that, but we, unfortunately, like everybody else, we're also restricted with our funding. And so we were requested to do, requested to do a specific one on people living with HIV just because of the co-infection rates in some countries. And the fact that people living with HIV, the #1 cause of death right now is tuberculosis. So to really have a specific focus on them. But I completely agree that if we looked at immunocompromised, we would be able to pick up a lot more people. But that's why we're developing the framework so that countries will be able to then identify their own key populations. All we're doing with our guides are trying to give some overarching, globally, these are some of the groups that pop up. But in your specific context, we really would prefer for us to not label what the key populations are, but for countries to be able to find their own and address them in the way that fits your specific needs, rather than us dictating. So, but I absolutely take that on board. And so if we are able to do any others, we will definitely try and do that.
Jonathan, what do you have to say about transition, actually? I'm really looking forward to hear about that.
Yeah, I think we're looking at a really dangerous situation right now. And like I mentioned in the presentation, where are people dying of tuberculosis at the greatest numbers? They're dying in these middle-income countries, the ones which the Global Fund is transitioning out of. And are these countries ready to transition? The obvious answer is no. They're not ready for many reasons. And if you look at what happened when the Global Fund transitioned out of Romania for HIV, we have a really obvious example of what we can expect with TB. When the Global Fund HIV funding ended, rates of HIV went up, Hep C went up, harm reduction services ended, needle exchange ended. It became practically unavailable. Even now, it's very limited. There's a few really good NGOs doing that work. But those services were not replaced by the government. And anyone who thinks that these national governments in Eastern Europe are going to step in and fill in the services which the Global Fund is providing for TB are mistaken. And one reason is that the legal and regulatory frameworks are not in place even to allow them to do that. Romania can't use its national funds to buy these drugs. There's import waivers, and if the money is foreign donations, for example, the Norwegian funds, they're able to get it through GDF. The national government is not able to do that. So it's really a case where the drugs are not going to come in, and the patients are going to die. And that needs to get fixed before we can even talk about transition. And really, I think the people who will be hurt the most by this are the most vulnerable. We need to be careful. So I would say we need to freeze transitions and make sure these countries are actually in a place to responsibly do it. Otherwise, we're letting the patients die.
Colleen, you want to say something?
So, with transition,
Is
this on?
Eva's voice that I'm
This
hearing?
is what is no, but with transition, we have to be able to get people to understand that GDP is not the means by which is not the indicator that we use in order to transition a country. If we're going to look at a country, it needs to be a holistic approach. It needs to be, if we remove funding from this country, who will be most at risk? Whose human rights will be abused the most? And of course, if I'm thinking of middle income countries, Central Asia, Eastern Europe, where key populations like people living with HIV, people who use drugs, for example, are criminalized, are marginalized. MSM have huge stigma and discrimination issues, for example, and these are all groups that also get tuberculosis. So we need to be able to push for, as much as we would like a freeze, I'm not sure if we can get that, but what I think we can do is really push for specific criteria. So when they're looking at the requirements that are needed for a country to transition, you have to have a legal framework that supports everyone, including key populations. You need to decriminalize certain groups. You need to, so I think we need to think a little more holistically about what are the requirements we need in order for a country to actually even begin thinking about transition. And out of the 10 countries that will transition over the next 3 to 10 years, it's in components. So it could be an HIV component, it could be TB, it could be malaria. 6 of the countries are TB in South America, in the Latin American region. And I don't hear any outcry about this. I don't hear any outcry about what are we doing? Is TB even covered by universal health coverage in these countries? Do people know their rights? What are their rights? So, I think that's some of the urgent action that's needed around this discussion is, what does it mean for my country if Global Fund leaves, right? And who are going to be the most at risk? Who are going to be the most disadvantaged? And then try and advocate for those criteria to be included in transition when they actually look at it.
If I can say something about that, coming from a country that was, I'm sorry to use the word, dumped by the Global Fund, it's really, when we talk about it as if under the Global Fund things were perfect. the program was barely functioning with the Global Fund money. And things just got started and going the right direction, and yet, like 5 years later, we're told that it's over. So I feel like when we talk about transition, we should also mention that things are not perfect under the Global Fund, that these CCMs are barely functioning, that there is no oversight, that there is no community participation. There is maybe community presence, but again, it's that community member who wants to do good but has no experience in oversight of grants and no force of proposition for things to move forward. So I think the transition is an issue, but that also doesn't mean that things under the Global Fund were perfect. At least that's one point. To go back to Lynette and Mike, the theme of the conference is confronting resistance. You've been confronting resistance, I think, for a long time and many years. So can you share some of the lessons learned on confronting resistance?
You want to start? Okay. I mean, who are you confronting, right? And what is this resistance? I mean, as an organization that's working around human rights, even within HIV, it took a very long time to confront the resistance everywhere you faced it. For tuberculosis, for instance, how have we confronted this resistance is in starting to see how patients are being treated in a healthcare facility, one, but also just starting to see what's happening just in general in public. For instance, this whole TB thing is really freaking me out, especially MDR TB, because currently in Swaziland, the doctors are scared because they're saying that patients refuse to take their medication because of the fact that they're worried about the time frame when they'll be weak and cannot go back to work, right? So they will lose their jobs. And there is no occupational safety net to catch them and to ensure that, for instance, there's disability cover to pay the salaries during that period. So, for instance, an example of something stark and is freaking us out is in Swaziland, we've got employees working in like a Walmart, right? Some of them cashiers. The doctor had one MDR patient at the beginning of this year. He's currently sitting with 15 in that same space who do not want to take treatment, who are not interested in ambulatory care because they just want to carry on working for their families. Now, if all of you in this room or some of you in this room are going to Swaziland in the next few days or in the next few months, just know that these things are out there and you might not, do you understand? Because it's not like a person with tuberculosis is going to have, with HIV, is going to present with these signs of lesions and, or, like looking like a zombie almost attacking you. No. It's just going to be somebody who's coughing, and it's just not, do you understand? That's how freaky it is. I'm sorry. I'm just going to be blunt. Do you understand? And this is the resistance that we need to be confronting, right? Whose responsibility is it to ensure that there is some sort of safety net? When we speak to the NTP, they say, no, it's not us. You need to speak to MOH, because that is where that the legal framework needs to come from. MOH says to us, wait, no, it's not our problem. You need to speak to the Department of... It's just cross-sectional in terms of department. Nobody's taking responsibility. That's one way where we need to, because it's really freaking. And on picking up on your point, Erica, around community mobilization, these are the types of things that we need to raise. So the Kenyan case did that, right? It started increasing people's curiosity in terms of them wanting to understand, why is TB not a crime? So us telling people that if you don't adhere, you get imprisoned. So do you understand that it's not as simple as just, for instance, having a cold and getting your medicines and being fine? You actually do get imprisoned. And until recently, that was happening in Kenya. The court case proved that, yes, of course, the practice should be abolished, but of course, in practical terms, it hasn't been. So this is where then the treatment literacy comes in, because you're building that momentum of communities who are able to stand up and confront this resistance. So there are ways, and I mean, as a person with a legal mind, I find those levers there, and the class actions are important because you're getting a large cohort of people fighting for one thing. And of course, HIV showed us that it can be done, and in TB it also can be done. So instead of the 111 cases that we've had so far, for instance, the case with the Baltimore prison, which really did, as much as it led to something, it didn't kind of like had that, strong offshoot that we need to see. Class actions, like we're seeing with the X-minors, are ways that we're going to confront this resistance.
Thanks. I wanted to just make one comment on global fund transition, and I'm wondering if instead of GDP as the indicator for when a country should transition, we should adopt Julian's test, the test you created around the young man that you met for a day, and ask, can a country in the absence of global fund support, post-transition, diagnose, treat, and cure a person like this? And if the answer is no, then maybe transition should be out of the cards. I said at the beginning that this was like the first time a human rights session has been held in an arena, but actually that's not true. I remember that in the Paris conference 3 years ago now, there was a human rights session on the last day held in the plenary hall after the plenary, and it was much like this, a small audience, an intimate one. There's nothing wrong with playing to a small room, but it was people pulled in at the last minute, people rearranging flights so they could stay and be a part of it, organized, very impromptu. And that makes me think that there's still some resistance within our community here, whether it's the union or the broader scientific community, to taking human rights as a discipline seriously. And Noma, thank you for taking our concerns back to the scientific committee tomorrow. I think that's a really important job, and I'm glad that you've offered to do that. But I would just point out to them that it's not hard to organize a human rights panel full of human rights experts, as Jonathan mentioned. We write a lot. We're all over the literature. We're not difficult to identify. It's a big community. Within TB, it's a small but growing community of people, and it should never be a last-minute affair to organize a human rights panel, and people who are rights experts should be speaking at union plenaries, as we do at every other global health conference, because the law, having lawyers in the room, is so important to a global health response. So the fact that we're in this situation now is really just, I think, unconscionable, and hopefully will never happen again, although I think what happened today was excellent, so I'm not totally disappointed with the outcome, but I think the setup could be better. You talked about treatment literacy, Lynette, and I think that's exactly right, and it answers Erica's question about demand generation, which is that we haven't done a good job connecting science to people, and we just have to do the really hard work of meeting in communities, in clinics, and patient groups, and making sure that people know about what is available to them and what their treatment is going to look like. And we haven't talked to people at all about TB prevention. And so within our treatment literacy efforts, we have to also make sure that we're talking about prevention in addition to diagnosis and treatment of active disease. And in addition to that, I think, if we want to look outside of that biomedical treatment literacy model, make sure that when we're doing this work, we're connecting it to bigger social justice issues like housing, like poverty alleviation, public transport and the systems that we need so that people can access health care. And it can all come together that way. So TB Proof is absolutely right. The sort of biosocial determinants of health need to be looked at. And I think that can be part of treatment literacy. They don't need to be two separate things.
Thank you, Mike. A last round of questions. Do we have, because we have a few minutes left. Yeah, go ahead.
Okay, so while we're, how does this turn on? Does it just, okay, it just comes on, okay. The one thing I wanted to raise is last night I had the privilege of being able to go to the Treatment Action Group symposium called Double Standards. And Salman Keshavji made an amazing presentation at the beginning where he talked about latent TB infection. I mean, we prefer to say TB infection, but TB infection and the numbers and what we can actually do. And, he pointed out the fact that a lot of us, because we get into the details on a daily basis, we actually miss the bigger picture. And if you look at the WHO guidelines on TB infection, it calls for treatment, so preventive therapy for a certain group of people. So it's middle, upper middle, and high-income countries, and not for low-income countries. And to me, that is colonial development. And how can we in this room in 2016 allow colonial development to continue? How do we think that it sits on our conscience that it's okay to say that someone in a rich country can have access to preventive therapy and someone in a poor country cannot. I'm a South African and Australian, so that means that in Australia I can access treatment, but in South Africa I cannot. And in South Africa, the only reason I can is because I have a government that is willing to provide it for me, not because WHO says I can. And so when these guidelines come out, we need to scrutinize them on a human rights, from a human rights perspective as well. It just cannot be biomedical. And I think someone here raised that point about biomedical versus human rights. And so, you know, it shouldn't be a versus. It should be that something that is put out by anyone when it comes to guidelines about how we should do something, that they should actually be equitable, that they should not discriminate. And if we see discrimination in our policies and our guidelines, we should be able to stop it. But I didn't see anybody say anything. There are a few of us saying it, but you know, when it comes to me saying something at a union conference, it's like, oh, it's Colleen again. She's going to swear and holler and scream, and do we really listen to her? But here's the thing. If all of us sit back and say that that kind of discrimination is okay, then it will continue, right? And we will allow colonial development to continue. And quite frankly, I don't believe we should anymore, right? In South Africa, if we could end apartheid, then we can sure as hell end colonial development. And I don't think we have a choice in that anymore if we're going to actually eliminate TB. So I really urge you to consider how you're going to look at guidelines when they come out. Because we can even be smarter than the guidelines that are put out and say, actually, you know what? This guideline is not accurate. This doesn't apply to everybody equitably. And using resource-poor settings as an excuse for not delivering an appropriate service is no longer appropriate. Yeah. You know, and we should say this. Do not further discriminate when we already face so much stigma on the ground. Why should we do it at other levels? So I really urge us all to continue to think about it in that way as well.
And I say we should put Colleen on these expert groups so she can scrutinize the guidelines beforehand. We don't need them to be released. I think we can do the job actually before or while they're written. I think I joined the gentleman to say that we should act upstream, and you're totally right about that. I've been just told that we need to wrap up the session. So if there is any burning questions, please go ahead. But otherwise, I think. Okay, quickly then. There is a 12 o'clock session and we need to free the room. So please, okay. I think, yeah, we're going to replace the mic.
Hello. Hi. Okay. Hi, my name is Haeyoung. I'm from the Global Fund. I work as a human rights advisor at the fund. Since the Global Fund has been mentioned a couple of times, I just want to make a short statement. But first of all, thank you so much for organizing the session. This has really been very interesting. And I'm very proud to say that we are supporting the ARASA, Kaelin, and Southern African Litigation Center for their human rights work in the context of HIV and TB. And those are only a few human rights organizations that Global Fund is supporting to do the work on human rights. We would like to see more of those organizations applying for our funding. And Colleen has mentioned Global Fund commitment on human rights, and I want to mention that Global Fund strategy since 2012 included specific focus on human rights, promotion and protection of human rights in the context of 3 diseases. And we have been promoting human rights programs to be included in the country funding request since 2012. But when we look at our funding request that has been received since in those periods up until now, we are seeing very little investment going to human rights programs, especially in the TB context. Malaria, we are seeing absolutely none. HIV, we are seeing great increase, but TB is still, we are falling much behind. And we mentioned the important human rights programs, for instance, strategic litigation. I think those are very useful, and LEA is very useful, and those are ones that we can fund if those are included in the country funding request. But for the country funding request, to have those programs, we really need to work with the national TB programs and Ministry of Health for them to understand these programs are important, because our funding request should be based on the national TB strategy or national HIV strategy. So the advocacy at the country level really push forward the Ministry of Health, the national TB, DP department to include those programs and be part of the country dialogue as a community or the civil society is truly important. And I just also mentioned I know the country dialogue process is a difficult process, and I know the Global Fund process is not easy for the communities and civil society to penetrate. But we have a support. We have TA programs that our department, Community Rights and Gender Department, is managing to support communities and civil society to better engage in the Global Fund process and country dialogue processes. So those civil societies can make a request to us, and we support your participation. But I don't think a lot of community members, civil society know that we have these programs. So I think with your help, we really need to communicate better that these supports are valuable and that we are really willing to help. Thank you.
Thank you so much. So I have to wrap up the session. I want to thank my panelists for really their valuable contribution. And the conversation should keep going. Hopefully we'll see you at the next union conference, but also in other sessions. And please join the union civil society listserv if you're not on it, and follow TAG on Twitter to get the latest on what's happening regarding treatment action group activities. Thank you.